everyone. I'm excited to be here. Thank you for having me. So I'll be speaking about carotid artery disease, specifically carotid endarterectomy versus stenting, and with a focus of where we stand in 2022. I have no relevant disclosures. So to start, carotid disease it accounts for about 10% of all ischemic strokes, and it's most commonly at the carotid bulb and the proximal ICA, with similar risk factors as for stroke and cardiovascular disease. Imaging is key and has come a long way since the initial studies of carotid stenting, endarterectomy, and medical therapy, and they're important for characterizing the lesion, seeing if there's associated silent infarcts, and evaluating distal anatomy to help make decisions between which is best, carotid stenting or endarterectomy. I'll explain a little bit more about that. Okay, so this is an axial CT on the right. You can see some examples of that the CT enables you to see some calcification to help with decision making. And then a coronal CT on the left, you can see the level of the lesion and how ugly that plaque looks and the degree of stenosis right there. Those are factors that would help you distinguish between somebody being a better candidate for carotid stenting versus endarterectomy. This is some angiographic images of the same patient from that CAT scan. You can see on the left the degree of stenosis of the proximal ICA right there. And this ugly plaque looks a bit different on the angiogram. There's some stasis within the plaque, which is a nidus for thrombus to form. And on the right side is after this patient was stented. Some noteworthy trials that are important to talk about when you talk about carotid endarterectomy and stenting versus medical therapy are NASIT, the North American Symptomatic Carotid Endarterectomy Trial, and the European Carotid Surgery Trial, which are from the 1991 and 1998 respectively, which established carotid endarterectomy versus as beneficial for preventing strokes compared to medical therapy alone. And CAS, which is the Asymptomatic Carotid Atherosclerosis Study in 1995, established that for stenosis greater than 60%, it's significant to prevent strokes to perform carotid endarterectomy as opposed to medical therapy. What's important to remember when talking about these studies is that the medical therapy at that time was very different than it is currently. It's advanced a lot since then. Those trials mostly were patients in the medical arm were just on aspirin. That's come a long way. And for the symptomatic trials, it was greater than 50% stenosis with more significant benefit for severe stenosis between 70 and 99%. Then trials that compared directly carotid stenting and CEA. One of the first ones worth mentioning is Sapphire, which was published in 2004, that showed that carotid stenting was non-inferior to CEA. However, there was selection bias, and the design wasn't optimal because it was a category of high-risk surgical patients. One of the most important studies that we continue to base a lot of decision-making off of today is a study called CREST, which was long-term results were published in 2016 that directly compared CEA versus CAS and showed that they had similar complication rates overall with the endpoints of death, MI, or stroke. However, with the breakdown of perioperative risk, the carotid stent arm had a higher risk of stroke, whereas the carotid endarterectomy arm had a higher risk of MI and death. What's also important to note is that in the carotid stenting, the higher risk for stroke was more commonly in patients who are older, which can have a lot to do with their anatomical, individual anatomic features, which I'll talk about in a bit. Yeah, and so another important trial that we're awaiting the results of, it's estimated to be published around 2026, currently enrolling patients, is CREST-2. What's important about CREST-2 is that it's a parallel study of carotid endarterectomy versus medical therapy and carotid stenting versus medical therapy. So 2 arms, which will answer the question of carotid stenting versus medical therapy, more modern medical therapy. So these are a couple of studies that have been published within the last 2 years that I included just briefly because there have been studies since CREST that are evaluating the question of whether carotid stenting is beneficial in comparison to just medical therapy alone, given that medical therapy has changed so much. But these studies often conclude that the design is not perfect for various reasons like selection bias of the patient population, the experience of the proceduralists who are included in the study, or a lot of them just kind of reestablish the conclusions from CREST 1. This is an example of, to this day in 2022, we continue to use the measurement techniques from NASIT and the ECST trial in angiography and CTA. Maximal medical therapy to this day, instead of just aspirin alone, includes high-dose statin therapy for stroke prevention, antithrombotics for patients who are intolerant to aspirin or non-responders to Plavix. There's more that have been developed since, over time, and better medications for hypertensive control, glycemics, helping with hyperglycemia, and helping with smoking cessation. So patients that are better for carotid endarterectomy would be patients who have low surgical risk generally, so no pulmonary or cardiac comorbidities or few, and anatomically favorable lesions. So if there's a concentric calcification that you can see on CTA or non-invasive imaging, then it's favorable to do CEA because the stent can only push the plaque so far out of the way with the constraints of the calcium. Other anatomical features that are favorable for CEA is if somebody has a type 3 arch or distal tortuosity, because that can create higher risk for stroke with carotid stenting. And another thing that is not standard to look at, but is definitely helpful from our perspective in neurosurgery, is looking at the distal collateral vessels. As you see in the photo there, during a carotid endarterectomy, you temporarily clamp the distal ICA in the proximal common, and you're cutting off the supply from that vessel for the period of time while you're operating. So it's lower risk to do that for a patient who has an anterior communicating artery or posterior communicating artery. Also important to recognize is that some of these trials consider old age as a high surgical risk feature. However, CREST-2 results showed that patients who are older than 70 had higher risk with carotid stenting. So it's important to continue to consider them for carotid endarterectomy, given their age. For carotid artery stenting, patients who are better, patients more favorable for stenting are, again, certain anatomical features. Such as the level of the lesion, if it's above the mandible or above the C3 vertebrae or below the clavicle, better suited for carotid stenting. If they've had prior neck radiation or a prior CEA that's restenosed, better for stenting. If they have a contralateral occlusion or tandem stenosis or isolated vasculature, like I mentioned, prior tracheostomy, or a contralateral laryngeal nerve palsy would be a reason to favor carotid artery stenting as well because of the higher risk of nerve palsies during carotid endarterectomy. And then back to just comorbidities as risk factors, cardiac risk, lung disease, and stage renal disease. I put age again with stars because the Center for Medicare and Medicaid Services guidelines include that patients will cover carotid stenting for patients who are older than 80. That conflicts with the CREST-2 study. So The guidelines by CMS, something in 2022 is that there are discussions going on of kind of updating those regulations and what's covered to better reflect the data and the data that we hope to have soon. Potential complications of either, I kind of pulled them together on this slide. The endpoints that I discussed previously from a lot of the trials: heart attack, stroke, and death. I discussed the breakdown a little bit already. Bleeding is a risk in both procedures, from an access site for carotid stenting or a neck hematoma for carotid endarterectomy, and an injury to cranial nerves is more common or more likely for carotid endarterectomy. And as well, restenosis is a possibility for both, so it's important to continue to manage atherosclerotic risk factors and continue with non-invasive surveillance after either stenting or a CEA. This chart is a neat little compilation of kind of the guidelines from the American Heart Association, American Stroke Association, multi-society guidelines, which date back to 2011. What it basically sums up is that symptomatic patients who are high risk for surgery, it's reasonable to consider carotid artery stenting for them, the high-risk features that I had mentioned. If they have unfavorable neck anatomy, it's also reasonable to consider carotid stenting for those patients. For symptomatic patients who are average surgical risk, it's important you can consider carotid stenting for them based on certain features. It's an individualized decision, but it's important that the degree of stenosis is greater than 70% on non-invasive imaging, greater than 50% on direct angiography, and that the procedural center and proceduralist have an anticipated perioperative risk of less than 6%. For asymptomatic high surgical risk patients, this is where the debate is kind of more ongoing. So there's equipoise between if CAS, medical therapy, or CEA are reasonable. And so it's important to make an individualized decision for the patient and discuss the pros and cons of each option thoroughly with the patient, as well as the anticipated perioperative risk based on the proceduralist and the center with the patient. And again, for asymptomatic patients who are high risk because of unfavorable and anatomical features, it's reasonable to consider carotid stenting as well. For average risk asymptomatic patients, it's not strongly supported to do carotid stenting for those patients. So in certain scenarios, it could be reasonable, but overall, it's not strongly supported and more research is needed. And I just wanted to put a little more focus on the patient-provider discussion that I just touched upon. You want to talk with them about the degree of stenosis. It's more favorable to intervene if a patient has a higher degree of stenosis, severe, between 70 and 99, particularly if it's asymptomatic. You want to explain to them that maximal medical therapy should be considered either way, and you want to pay special attention to their comorbidities and anatomical features and the perioperative risk of the surgeon and the center. These are my sources, and I wanted to wish everybody a happy PA week.